The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you for joining us today. The webinar will begin at the top of the hour in 2 minutes. Again, we will begin in 2 minutes. Thank you. Hello, everyone. Thank you for joining us today. The webinar will begin in 1 minute at the top of the hour. Again, we will begin in 1 minute. Thank you. Good day, and welcome to this Health Catalyst webinar. As a quick introduction, Health Catalyst is a next-generation data, analytics software, and decision support company committed to being a catalyst for massive, sustained healthcare improvements. My name is Sarah Stokes, and I will be your moderator today. Now let us begin with today's webinar, The Next Revolution in Healthcare, Why the New Mssp Revisions Matter Now More Than Ever, presented by Dr. Will Caldwell, Senior Vice President here at Health Catalyst. Dr. Caldwell has an MBA and is a triple board certified physician in head and neck surgery, allergy and immunology, and sleep medicine. In his current role as Senior Vice President for Physician and Market Development at Health Catalyst, he promotes the use of data analytics to promote good health and save lives. His area of expertise rests in technology-enabled healthcare delivery models and value-based care platforms. Throughout today's webinar, you will be presented with multiple poll questions. We encourage you to engage in those polls as they will help to drive today's conversation forward. We also urge you to submit questions throughout the presentation by using the questions pane in your GoToWebinar control panel. Dr. Caldwell will answer questions at the conclusion of the presentation in a Q&A session. We are recording today's webinar, and by midday tomorrow, you will receive an email with links to the recorded on-demand webinar, the presentation slides, and a transcript. If you would like to stay in the loop on upcoming webinars and all things Health Catalyst, you can follow us on social media. Our handle is @HealthCatalyst. I will now turn the time over to Dr. Caldwell. Dr. Caldwell?
Great, thank you. It's great to be here. So I am a physician, a surgeon, and deal with patients all day long. And we're sitting in a small padded room in Salt Lake City here doing webinars. So this is about as far from my area of comfort as it gets. But we're going to have a great time and talk a little bit about the Mssp. And my goal today really is to make people aware of some of the changes I think you're already aware of that are happening in healthcare, but also how the Mssp and other payer products are really agents of change and drivers of change here in the country. What we're not going to do is have a real technical discussion about the Mssp or how we populate the numerators of quality metrics, or we'll touch on that, and certainly Health Catalyst, and my role here at Health Catalyst is how do you embed technology into systems to drive success around payer products such as this and other things. So Health Catalyst can certainly answer those questions, and I can answer those questions, but that's not the technical aspect is not the focus of today. So let's get started. Studs Terkel is a wonderful, or was a wonderful writer. He was a radio personality that did a lot of interviews back in the day. I think he passed away a couple of years ago. This particular book I would recommend to you. It's coming of age. And my first kind of iteration of interpreting this book, I was traveling and interviewing for residency. And it's a collection of interviews that Studs did with people all across America. And it was their reflections at that time on the 20th century in the lives that they had lived. And most were in their 70s and 80s and some in their 90s. And they were from all different walks of life. But they were truly extraordinary individuals. And I remember reading this and thinking, what are the common characteristics of these individuals? Well, one, they were all very passionate about whatever they were doing, whether they were educators, whether they were teachers, doctors, tech folks. Two, they didn't quit working, and so they were all still working in their 70s, 80s, and 90s. And then last, they at some point in their career had taken a significant risk to themselves, either physically in the case of labor lawyers, economically, but they had taken some degree of risk. The interesting thing is they all were extraordinary people, and they all had impacts on people around them, and that's why they were included in the book. As I look back on this book, though, the second kind of iteration of my understanding is more around the individuals within the book that had a scalable impact. And what I mean by that is they all had impacts, but who really helped to change, who created a paradigm shift or led to something that impacted society or culture as a whole? And what I realized is that it wasn't so much the people, it was the conditions, it was history, it was the opportunity they were afforded by the very training they had or where they happened to find themselves at that time or that point in history. And so what just to kick us off, what I would say is that we have just an awesome opportunity in healthcare, and that's why I'm here at Catalyst, and to participate in what is maybe the biggest societal shift of my generation and that after me. And really, it's the move in the use of data and the move away from kind of our fee-for-service payer model to a value-based care model. And I think all of those folks that are on this webinar, number one, are likely in healthcare, certainly receive healthcare if you're not providing it. And so we're all vested in this. And I think secondly, most of the people on this webinar have some understanding and some of us considerable understanding of the importance of data and helping to drive that change. And so with that, I wanted to start out with a poll question. How many of the world's 1-year-old children today have been vaccinated against some diseases? So remember, these are all kids in all parts of the world, poor, wealthy, impoverished, developed. So we'll give you a few minutes to respond.
All right, the votes are pouring in. We've already had more than 50% of the audience vote. So you're getting great responses so far. Okay, we'll leave this open for just one more moment. And if you joined late, we are recording today's session. The slides will be available after the fact. We're going to go ahead and close that poll now, and I will share the results. All right, so 52% of our audience today thought 20%, 37% thought 50%, and 12% thought 80%.
All right. We have a pessimistic group, but a typical group, and we'll touch on that here in just a second. I wanted to just touch on why data matters and have a little fun to kick us off. And the question that I pose is the fourth question, I guess, on this list. But all of these questions come from Hans Rowling and Factfulness book. And basically what he suggests is that there's a misunderstanding of where we are in the world.
Sorry, your slides are actually frozen, so I'm going to just take over as the presenter here.
And so there's a misunderstanding of how data is used and people's understanding, and actually things are a whole lot better than we had feared. And so the right answer for all of those that are on the edge of their seat is actually 80%. So 80% of the world's 1-year-old children today have been vaccinated against some diseases. If you take a look at...
Sorry, I have to find my mouse here. There we go.
If you take a look at how people responded to this, and this is directly from the author's website, very few across a series of 13 questions, similar to the ones that I posed, got it right. And so there were 13 questions, there were 3 answers to each question. And so Hans said that, you would expect monkeys picking from 3 tables of bananas to get at least 33% of the answers right. And as you can see, the people that respond, people like me, people like many of those on the webinar, And by the way, this was given in Davos at the World's Economic Forum. This was given to a group of Nobel Prize winners. This was given to a group of healthcare executives, and they all scored very, very poorly, actually worse than you would expect monkeys to score on this particular questionnaire. And so I think the two things that I'd like to point out: the world is in a much better place than it was. Number one, and number two, there's a basic misunderstanding in facts. And I think part of what we need to do as healthcare providers is use data to help resolve that problem. And so just kind of a fun example, I would encourage you to take a look at this book. It's a great book if you're interested in how we use data, and I would recommend it to you. If you look at kind of how healthcare has developed over the past century or a bit more here in the United States and the world, we've made dramatic improvements in all aspects, in all measures of healthcare quality and outcomes. And what I'd like to suggest today is that the development of our healthcare system, at least in the United States, has been the result of a series of revolutions. And if you take child mortality and you look in the upper left corner in 1800, about half of all children died by the age of 5. So half of all children were dead by the age of 5. If you fast forward 100 years to 1900, in some areas of the world, like the United States, parts of Europe, you're starting to see improvements in child mortality down the 30% range or so, 20% range. And fast forward to 1948, now you're seeing, and if you take the United States, we're down 5%, 4%, 3%. And if you look at 2015 data, we're far below that. So less than 1% child mortality rate in the United States. And more importantly, if you look across the globe, you've seen concomitant reductions in child mortality pretty much everywhere that we have data, almost everywhere. The point I like to make is this didn't happen by accident. This was really a series of revolutions. And so, 1900, we had something happening with industry and really an industrial revolution in parts of the world, such as the United States. And that led to profits, that led to financial gains and development, which led to a tax base, which led to the ability of the government to create hospitals and medical schools and educational institutions. And as a result, you started to see a reduction in things like child mortality. If you then look through kind of 1900 to 1930, we really had a cultural revolution. So industrial revolution, now more of a quality revolution. And that quality revolution was in large part spurred by things like the Flexner Report that the federal government initiated and said, hey, let's take a look at the quality of care being provided in hospitals and by physicians and the quality of training that our physicians and providers are getting in medical schools in the United States. What we found is that it was pretty lousy. And in fact, as a result of the Flexner Report, almost half of medical schools and hospitals across the country were closed. They were shuttered. As a result of that report, we began to put processes into effect by which states were granted rights to license hospitals and medical schools, and a lot of those things that were instituted still persist today. And so you started to see further reductions in things like child mortality as we had this ongoing quality revolution way before Toyota made it famous. We were doing this in real time here in the United States in healthcare. A couple of things happened in 1948, and there's a big difference in 20-30% childhood mortality rate down to 2-4%, which you see in the bottom left corner. And most of these things were due to changes in public health. And most of these things, like building schools and hospitals, were facilitated again by money, by taxes, because they were changes that were instituted by the government, not by private individuals. And really, there were two primary drivers of that reduction in child mortality. 1948. And the first, I always ask folks this, and they always say vaccinations or antibiotics, and as physicians always respond. But really, it has nothing to do with what I do as a physician or what I would have done in 1948. It has to do with the pasteurization of milk products, number one, and the creation of sanitary sewer systems. Neither of those things is what we typically think of as healthcare in the United States, but I would point out that it resulted in the largest reduction in child mortality of anything that we've been able to do. And if you look to 2015, you've really seen a very nominal improvement in child mortality as compared to the reduction seen in the 1940s from those public health efforts. So, I think the answer here, or the point here, is that this didn't happen by accident. It was a series of revolutions that led us to where we are today. And not only have we benefited in the developed world, but many other parts of the world have benefited from these revolutions. I spend part of my time working as the senior health advisor with a group, Zanmi Lasante Partners in Health, and Paul Farmer's a colleague, and I love this quote that the idea that some lives matter less is the root of all that is wrong with the world. And I think that that's so true. This is a book many of you have probably read. If you haven't, I would recommend it. And the reason I would recommend it is that I think it speaks to care delivery model design. And I think we could learn a lot in the United States from things like community health workers and the training of health workers and their use in our current system. And we'll touch on that a bit later. But wonderful book. We've got a video we're not going to play, but I am going to recommend that you take a look at it at your leisure. It's about 6 minutes long. And the reason I'd like you to look at it is a couple of things. Number one, it talks a little bit about, or it shows you really, a hospital in Leakage, Haiti, in Southwest Haiti, where we do some work. And what you see is that the hospital's in disrepair. And so, Haiti's a country that really has not had an industrial revolution, right? Haiti's a country that really has not had the quality revolution, certainly hasn't had a hygiene revolution. And so they've missed some revolutions, but there are some things at the end of the video that I think would be encouraging and would again speak to some aspects of care delivery that I think we can learn from, particularly with a program like the Medicare Shared Savings Program, and particularly with a lot of the value-based Medicaid programs that are coming up in many of the states, and that's the use of community health workers. Community health workers, many of you are probably familiar with, but they are really frontline workers in many parts of the world that are very, very effective at promoting better health and higher quality of living, higher standards of living for people in some of the most impoverished, challenging places in the world to live. They're very cost effective. They're effective not only because of their training, but because they really break down those things we call the social determinants of health, and that they really understand the challenges of the people they care for. Now, we have these programs in the United States, and they started in some places decades ago, like in San Francisco, Minnesota, and other places. But for the most part, we've not scaled community health worker programs. And I would ask you to kind of ask yourself why. Why have those programs not been more scalable or more publicized or more utilized in the United States healthcare system, when we know that the impact on patients' health and addressing many of the inequities within our health system, they handle that very well. They're very effective. And I think the answer is that it hasn't been, the economic incentives have not been aligned. There has not been a mechanism for providers and health systems to be paid for the use of health workers to keep patients healthy and out of the hospitals and out of the exam rooms and away from the CT scanners and out of the hospital beds. And one of the exciting things, again, And the revolution that I think we're heading into in healthcare is a payer model revolution. And more you're going to begin to see things like community health worker programs not only become beneficial, but really mandatory and instrumental in leading change through financial success. And we, as physicians and at Health Catalyst, had a great conversation with a group of our sales folks this morning here in Salt Lake. And Catalyst is an incredibly mission-driven company, as many of you are, and many of your companies. And we want to help. We want to make the world a better place. We want to address disease. We want to address poverty and inequities in the system. And what I would argue is that the way we do that, we talk about sustainable change or improvements in patient outcome here at Health Catalyst. The sustainable part to me, at least in our market culture, really is determined by whether or not we can make it financially viable. And it's a fine line to walk because it's not all about making money. But in terms of making many of these changes sustainable, which ultimately lead to sustainable patient outcomes, we've got to begin to change how we think about reimbursements and payment models. So I think, the message is across our country and the world, we've certainly raised the bar. Everybody's much better off living in 2019 than they were in 1800 in terms of healthcare, and that's not arguable. There's no argument there. The data bears that out. I think the Gini coefficient, which essentially is, many of you know, something that measures the distribution of healthcare, or really the distribution of, or the difference between any metrics, poverty, access to education, but it's more of a distribution coefficient, is going up. And so although the bar is going up for everyone, everybody's in a better place, the inequality between haves and have-nots is also going up in many ways. And so I won't read through this, but you can see that there's still work to do, and it's just not right. I don't think anybody would agree that just because you're born into a poor household, that you should be twice as likely to die before the age of 5. Again, childhood mortality is way down, but if it's your child that dies, statistics don't matter, right? So I think the other comment I would make as a physician, and we're starting to see this, is that traditionally physicians have thought about healthcare in terms of, in quality of care, in terms of what we do for patients in a scientific or medical sense. So what disease do we diagnose? What disease do we treat? How effective are we at treating it? I think we're starting to understand that there are limits to how effective we can be if we're not also addressing things like social determinants and, frankly, economic drivers. And so I think some of the most extraordinary physician colleagues I have really think about that when they're prescribing a medication or ordering a test. One, does the patient have access to this realistically? And two, do they have access to transportation to get to their CT scan? And I think it's starting to change utilization patterns, at least among some of the more exceptional physicians. Another book, and I read a lot, so forgive me, but I always kind of pepper in these books and talks that I would recommend, is William McCaskill's Doing Good Better. It's a wonderful, wonderful book, particularly for those of us that like data, because it's a way to begin to answer the question of why do you give money or support charities that you support. And he doesn't say this, but what I interpret from his book in many ways is that there are moral reasons to give to others. There are also psychological and emotional ones. And it's not that any of those are wrong, but I think it's just helpful to understand what the motives are within ourselves and why we give to what we give. And so I'd recommend that. I think it's a wonderful, wonderful book. So what's the next revolution in healthcare? I don't know what you call it, but I think it's some sort of a payer model revolution, right? It's, how do we move from this traditional fee-for-service model to more of a value-based care model How do you create kind of scalable, sustainable improvements in patient outcomes? And I would argue that that making money or making the provision of healthcare profitable, particularly in our market economy, is not a result of our efforts, but actually is a mechanism to achieve success in driving sustainable patient outcomes. And so at Health Catalyst, and you're all familiar with the quadruple aim, I won't go through it, but the point I like to make is value-based care. Value is defined very differently by different folks, and certainly I spend a lot of my time out in the field talking to customers and folks about this. And I think it's really important to understand fee-for-service, value-based care, and where you are on that spectrum. And I mean, data management is central to any definition of value. So data is always important, regardless of what you're trying to do. I think if you look at, I'll give you a quick example. If you look at even a fee-for-service type model, if you take the Mssp, a shared savings model, something like risk scoring on the front end is really important to your financial success or failure within a shared savings model. I would argue that it's much easier to accurately risk score and adjust your risk score. In most cases, you're adjusting your benchmark upwards, appropriately so, by accurately risk scoring. You can certainly increase your benchmark in the Mssp program on the front end much more easily in many cases than you can reduce the total cost of care on the back end. In the end, you still achieve shared savings. It's just easier to do and appropriate. You're coding appropriately. So something like risk scoring is important in that fee-for-service model. However, if you look at something like the Cigna CAC, which is a care coordination PMPM model, that's not true. Risk scoring really, there is some impact, but it's far less than that in the Mssp. And so I think what we try to do at Catalyst is to come in with a questioning attitude, understand that everybody's in a different place on the spectrum. Hopefully everybody's moving towards value-based care. But we're realistic and pragmatic about it. And we realize that there are different data analytics tools that drive success depending where you are on that spectrum. And so, what I would say is in your own independent of Catalyst, in your own company, it's really important to make sure that everybody's swimming in the same direction, rowing in the same direction, that really understands, one, where you are today on that spectrum, but what are your aspirational goals 5 years from now? If there's discordance, say between your executive team and others in the company around this particular goal, it makes it very difficult for any vendor or any partner like Catalyst to come in and recommend the appropriate data analytics tools and platforms to drive success, because you're not agreeing on what you're trying to succeed in. Another video I'm not going to play, but this is a wonderful video of Steve Jobs responding to a very difficult question in a group of people. And what I like about it is that he talks about listening to the customer and not creating technology first and then trying to apply that technology or adapt that technology to the customer's needs, but starting the other way around. And it resonated with me because that's how we think about it here at Health Catalyst. And so I'd encourage you to take a look at this. I think it's entertaining. It's a wonderful 6-minute answer to a difficult question. And rather than my talk about kind of how Catalyst engages customers, I think you'll get a good idea from his response. So is the shift to value real? I mean, I get this all the time. Like, come on, we tried this back in the 80s or 90s, and what's different about today? Well, let's just answer that question with some data. So fee-for-service is declining by every metric and every report. This came out in October of 18. We're looking at the number of total healthcare payments linked to some value-based model. Think about this. So it was 34% in 2017. In 2 years, that's up 23%. That's a huge change. I hear this is all just a phase. This is something we need to move through. We don't want to kill the goose that laid the golden egg, which is fee-for-service. Why are we talking about this? And I think that you hear this in different parts of the country. Some parts of the country are way ahead of other parts of the country in this regard in understanding this move to value. But all of the payers are following suit in their move and focus on value. And it's working. So if you look at Medicare, despite what the industry may highlight, there is a reduction in utilization by over $1 billion. And I think that's significant. 34% of ACOs earned a shared savings bonus, and this is prior to the recent changes pushing people to downside risk. So I expect that number to go way up, and I think ACOs really are beginning to hit their stride. I don't think they're going away. Medicare Advantage is the same. We're seeing an increased number of Medicare Advantage plans, and so that brings me to the second poll question. With any major societal change in a developed society like the United States, what changes first? What happens first? Do attitudes lead change, or do laws and regulations lead change? So let me stop and we'll let you guys respond.
All right, great. We've already had over 40% of the audience respond. Again, to anyone joining late, we encourage you to submit questions throughout Dr. Caldwell's presentation. He will be addressing those in a Q&A at the end of today's session. We also are recording today's session and posting it afterwards, so you will have access to that as well as the slides. All right, the votes are starting to slow down. I'm going to go ahead and close that poll and share the results. All right, so it looks like 61% said people's attitudes and 39% said laws and regulations.
Yeah, and this is typical. I mean, when I ask this question, particularly among nice, optimistic people, which is a lot of healthcare, by the way. This is absolutely the breakdown in how it's answered. It's usually 2 to 1 that attitudes lead significant societal change or paradigm shifts. I would push back, and I would argue that that's not the case, particularly in a market economy. If you look back, it's something. Let's take, for example, race relations in the United States, desegregation, civil rights. Certainly, there were people, as are on this WebEx or webinar, that that really believed that those things were wrong and wanted to change them. Absolutely. But I would argue that the change in civil rights did not come from people's attitudes changing primarily. At first, it came from a change in laws and regulations. And so, and you could look at any major societal shift, and you could look at labor law, for instance, and laws and regulations, at least in a market economy in the developed world, have always been the leader for shifts in attitude. And attitudes often take decades to change, and sometimes generations, right? With new generations coming out and viewing the world through a different lens. And so that's why I'm so excited about the Medicare Shared Savings Program. And why are we talking about this? Well, if you look at the statistic at the top of the slide, in just 3 years, about 40% of all covered lives in the U.S. healthcare system will either be part of Medicare or Medicaid. And I think that what you're seeing in the Mssp, which began in 2012 following the Affordable Care Act and was revised late last year, you're seeing Medicaid programs in states around the country following suit, oftentimes using the same payment methodology and same quality metrics. And so the Medicare Shared Savings Program, I would argue, is the financial push that will help move this country into away from fee-for-service and into value-based care. When we talk about the Mssp, as many of you know, is a shared savings model, which means you have to meet certain quality metrics, but you also have to lower the total cost of care. And if in the past, if you haven't done that, you didn't get paid a bonus over and above your fee-for-service revenue. And going forward with the changes in the Mssp legislation and the move to downside risk earlier, now you're going to have to pay if your total cost of care increases at least a portion of that up to a point. So, when we go out and we talk to many systems and IDNs across the country, honestly, quality is expected and has been for a while, and there has been more of a cultural shift around quality, and that has led to really total cost of care is the bigger challenge that I find when I go out and talk to companies. How to use data to lower total cost of care while maintaining quality. So we talked about the revisions. It is a burning platform. I won't go through each of these. I think you guys probably are aware of this. You can take a look at some of these things that really make the changes in the Mssp incredibly important to understand and plan for if you're a system or a healthcare provider. This is what I like. And how do you succeed in the revised Mssp? We believe at Health Catalyst that you have to embed technology within care model design. So we talk about technology and we talk about professional services. So we have to listen, we have to understand what is the problem that the partner is trying to address. And then we have to figure out, does the current care model support success in the program? And if so, what technology can we embed into that care model? Or do we need to shift that care model? But what we've found is that simply providing technology by itself, while it's a key component to success in a shared savings model, doesn't necessarily drive adoption and doesn't necessarily drive success. And so all of these things that are listed are incredibly important and represent not only technology but care model design. At Catalyst, I'm not going to touch on this. Well, I'm not going to get into this more than to say that this is an example of some of the things that we offer. We talk about DOS. It's our data operating system. It's really an enterprise-wide data warehouse that's really an open platform. It's really a wonderful way to democratize data, to bring in disparate sources of data. And I think as we get more and more into value-based programs, particularly looking at things like social determinants and how do we incorporate that into medical decision making, having a diverse set of data is going to be incredibly important. I won't go through each of these. Some are self-explanatory, some are not. I do want to touch on Touchstone and the KPA tool. Benchmarks are really important with value-based care, and we believe, back to my quality comment, that a lot of folks are already achieving very high levels of quality on many of these metrics. And Touchstone is an external benchmarking tool that we have where our clients are able to compare their success or degrees of success to external benchmarks across the country, de-identified patient data, and I think that's incredibly valuable. But what I would argue is that for many of us that already achieve very high levels of quality, the KPA tool may be more important because it's really a measure of internal benchmarking, and it allows you to recognize, yeah, you may be the 78th percentile or 90th percentile, but once again, if you're the 1 in 10 that's not benefiting from whatever that metric is, it doesn't really matter to you, right? So we want to make sure that we improve, and that's what the KPA tool does. So as many of you probably know, the Mssp program changed quite a bit, and I put this in just for your reference. You can look back to it. This summary slide, what I'm pointing out here, two things. One, they've divided customers into low revenue ACOs and high revenue ACOs or entities. Health systems, think of as high revenue ACOs. The federal government and the creation and revision of this program is really driving people to risk much sooner in the process. And so the days of, I was at a large health system prior to being with Catalyst, the days of, hey, let's prepare, let's figure out what we need to succeed in value-based care. And while all that's good, now there really is a burning platform because we're starting to get into significant downside risk. And I think ultimately what will happen is it'll move also to the question of of access and what patients you'll be able to see, particularly with commercial payers that begin to create narrow networks based on value. These are just the metrics that just be aware that they've changed. They've removed some and added some. And so here are some things that I hear on the road. We have such a small amount of our total revenue in value-based products. So I hear this a lot from usually C-suite executives. And I think it's interesting to really think about this because this came out of some of my friends and colleagues at McKinsey. We discussed some of this 2-3 months ago, and they recently came out with a paper in April. It's a wonderful paper. I'd recommend you look it up. I think it's out. If not, it'll be out in a week or so. But they point out that despite the relatively small effect on overall revenue, value-based care arrangements often have disproportionate margin impact. And so the example is, given a 5% operating margin, a system would need to only have 1 to 2.5% of revenue at risk from value-based care payments for upside or downside revenue potential to equal 20 to 50% of the system-wide EBITDA. And so the notion that it's a small amount of total revenue is true, but it can have a disproportionate amount on your profitability and your operating margins. And so, and then there's a quote, Jordan Van Laer, a good friend at McKinsey, and others did a study that I think was originally published in New England Journal a few years back, but they looked at 4,000 health systems, and about 20% of those, you can see the upside potential in value-based care just for Medicare fee-for-service programs alone is greater than their total reported operating margin. So when you think about contribution margin, value-based care products matter. The second thing I hear is that it just doesn't make sense to cannibalize our fee-for-service business. I mean, this is the tension, right? So you want to take good care of patients, but you want to stay in business. And if you're decreasing utilization of hospital services and you're a hospital company, in the short term, that's understandably scary, right? And so there is this tension, and I think that it's a healthy tension. And so what I would challenge you, particularly with something like the Medicare Shared Savings Program, is to understand that if your shared savings rate, regardless of what your value-based program is, if your shared savings rate is greater than your operating margin for a given population, and you have to add in additional fixed cost, which are often negligible for the most part, or nominal at least. But if your shared savings rate is greater than your operating margin, it actually makes sense, financial sense, to participate in the product because you're going to make more money. And not only does it make financial sense, but that financial success leads to clinical success because, again, what are we talking about? We're talking about keeping patients healthy, keeping patients out of the hospital. We're also talking about keeping patients financially healthy. You know, the burden of healthcare costs is felt by individuals, by people, by our relatives, by our neighbors, by members of our community. It's a cause of bankruptcy in many cases. It's certainly a cause of stress in people that don't need stress, sick people. So if it's a reasonable argument. However, I think that we at Catalyst recognize that we can use technology and data to highlight physician behavior that can, for example, lead to improved retention of patients within a system, decreased leakage of patients outside of a system, and also reduce unnecessary utilization or increase variation in care. And so when you link two of those things together, right? And when I talk about decreasing leakage, why do we want to do that? Well, if you've got a clinically integrated network and you're providing high quality care at the lowest cost possible and achieving high rates of patient satisfaction, wouldn't you want patients to stay in your network? If they leave, you can't control any of those things, the quality or the cost. And so retention of patients is important. And so an example, if you move your retention from 50 to 60%, in other words, decrease your leakage, so to speak, by 10%, that's equivalent to a 10% growth in top line volume. Okay, so if you reduce unnecessary utilization by 10%, well, now you've got a wash, right? And everybody wins. And so I think there's smart ways to think about realistically, pragmatically think about what technology can I use and embed in very thoughtful care delivery models that can really allow you to have your cake and eat it too, and ultimately lead to the changes that we want to see in the American healthcare system. You know, the MSSP. I hope you are getting. You know, I feel that this is going to be an incredibly important driver towards value for our country. This is a mock-up, and these are actually real numbers of a health system in the Southeast. And so I just wanted to go through it because I think that people are often surprised by the potential economic impact of either success or failure in the new program. And so I pulled these numbers, and again, these are a real system. So from the cost report, the Medicare payments of $291 million, representing 31% of net revenue. Made the assumption that this particular system was achieving the 70th percentile. And I won't go through, I'd be happy to offline, or how that percentile is calculated. Most of you probably know it. It's based on quality measures, and you have to achieve a certain baseline of 30% to be eligible for shared savings. And then the degree to which you can achieve your maximum shared savings rate is determined by where you are between 30% and 99% or 90%. Doesn't go above 90% percentile. But you need to be about one standard deviation from the mean and your regional benchmark to achieve your maximum shared savings is a good rule of thumb. So it's about the 68th to 70th percentile. This actually was borne out by this particular example at 70th percentile at 42.5% of shared savings. The per capita total cost of care benchmark is going to be unique to each system. This is something that many of you know is determined by CMS. And this particular number was, in this particular example, they're not part of the MSSP program yet. So we took an average of similar systems, both in terms of patient makeup and geography. And this is something that Catalyst helped do to help have a prediction of where your benchmark might be at $8,900, and then recognize that this is the benchmark that can be adjusted based on risk coding. And so CMS assigns a benchmark for the lifetime of the 5-year plan. For the most part, it doesn't move much. And once it's established, and going into this program, you therefore want to make sure that your risk coding is correct. So again, you know, this is something that Catalyst has helped clients with, and in many cases moved the benchmark 5, 8, 10% in cases. And again, it's a whole lot easier to move a benchmark north by 5% than it is ahead of time than to reduce total cost of care on the back end. And so this is really critical. So that's the benchmark. This particular system had 57,000 lives in their MSSP, or we estimated that. We helped them determine what percentage of their current Medicare population would be included in their program. We assumed a 4% total cost of care savings. So in year one, at a 40% shared savings rate, it's $8.1 million. In year two, assuming they increase their quality percentile a few percent, they achieved the 50% of shared savings in year two, and that's $10 million. And then if you go to the next slide, I said, well, what are the potential losses in year two? Again, this is a new entrant to the program. So in the first year, they have no downside risk, but in year two, they do. Really, it's at 18 months, or would have been earlier this year. And so the shared loss rate is 30% with maximum 1% of benchmark. So I just took 1% of their benchmark at $89, said, what is their shared loss rate? 30%, that's $27 per capita loss, times 57,000 lives, it's $1.54 million potential loss in year two. And so that's a delta of 19.7 million. Now, the thing I would point out is that this is just shared savings payment. And so this is not revenue. This is a direct impact on contribution margin. Direct impact on contribution margin. And so this is why there's a disproportionate impact on margins. as compared to revenue, and I think that's critical to understand. So how do you impact total cost of care? Those are things that we help with through technology and services. And people talk about, well, how much does this cost? Well, I would point you back to your investment in your EMR. And then I would also point out, how many of your providers are excited about their EMR and its ability to improve patient care, and then begin to ask, what should you invest in data analytics tools? I'll tell you, and this is a positive thing. I think that the Affordable Care Act and other regulatory changes have encouraged us to all get to digitize healthcare through requirements of having EMRs in offices and health systems. That's also created some cynicism among providers. I mean, as an ENT provider, maybe your quality metric is diastolic blood pressures. Well, that doesn't mean a whole lot to me in terms of how I take care of patients, but I get paid some meaningful use measure potentially. And so a lot of cynicism has been created, and most providers think of technology as being the EMR in a box checking exercise. And I would argue that EMRs have improved. They're necessary. They're wonderful transactional tools, and they're good at what they do. But if you can bring in a strong data analytics platform and the tools and put those tools in the hands of physicians and providers and really help begin to define what data can mean to those individuals as providers and those caretakers of patients, they can begin to answer their own questions. And we're going to begin to change the discussion, and that cynicism is going to turn to excitement. And physicians are going to say, wow, this is wonderful. And so don't stop with your EMR. Look for a data analytics platform because it really matters. The last thing I'd like to end on is a quick story. Jaime Aramillo is in Colombia, lived in Bogota, grew up there. And Jaime I believe he was 19 or 20 years old, and he was sitting in a cafe on a street corner in Bogota. And at that time, there still is an issue with orphans, street children, in various parts of the impoverished world, and it was a big problem in Colombia. And many of these kids, they were called sewer children, and they lived in the sewers and they begged for food, and it was just a real problem and a real tragedy for these children. Well, Jaime was sitting having his coffee, and he was really trying to decide what he wanted to do with his life. And he looked across the street, and there was this young 10-year-old girl standing on the sidewalk. And this really resonates with me. I have two 11-year-old daughters. And Jaime caught the eyes of this young girl, and she looked at him and smiled. And about that time, a car drove up, and the window rolled down, and out the window they threw a toy, a doll or a truck, a toy, and the car drove off. And the girl was incredibly excited, and she stepped out, and she picked this toy up, and she looked across the street at Jaime, and he tells the story that she had this look of pure happiness on her face, and they were connecting, and it's just a beautiful moment. And out of nowhere, boom, a car came around the corner and hit the child, and the child was killed, and that life was extinguished in a matter of seconds. And what was a terrible event for obviously that child, but also for Jaime, was a pivotal event in his life. And what he said to himself was, you know what, this is a problem, and I now recognize this problem, and we're going to try to fix it. And Jaime went on to create a charity that has literally saved the lives and improved the lives of over 40,000 street children in Bogota, Colombia. And he now has business people, doctors, lawyers, soccer stars that were amongst these kids that come back and credit Jaime with saving their lives. And I think what we can learn from this is that if you're in the right place at the right time and you pay attention and you care, you can make a difference, and you can make a scalable difference, particularly in healthcare. And so I encourage all of you to embrace the Mssp, embrace these changes towards value, recognize that you're in a unique position to not only impact the person beside you or your communities around you, but as healthcare providers who are interested in data and are understanding about how data analytics can lead to success, you can actually impact millions and millions of people through your work. So thank you for your attention, and we will, what do we do now? We open it up for Q&A?
I'm going to open one last poll question, and then we're going to dive into the Q&A. So let me just get this queued up. Okay. All right, so in this poll question, while today's topic was an educational webinar focused on the Medicare Shared Savings Program, some of you may want to know more about Health Catalyst products or professional services or the work that we're doing in this space. If you would like to learn more, please answer this poll question. And we're going to go ahead and leave that open as we dive into the Q&A. So let me pull up the questions here. All right, we're just going to start at the top. You all right with that there, Dr. Caldwell?
Sure.
All right, so the first question comes from Jeff, and this is fairly early on in the presentation. And he said, data and insights are great, but we know that evidence-based medicine has poor adherence. What is Health Catalyst doing about having data drive provider and business leader behavior?
Oh, I'm sorry, I'm looking here. This is a different
down here, yep.
So data insights are great, but we know that evidence-based medicine has poor adherence. So I think it's a great question. So I think a couple of thoughts. I mean, I'll speak as a physician. So because I think adoption of change and adoption of data and data-driven change, you've got to foster adoption at the clinician level, the provider level. I mean, that's where decisions are made. People often say, you know, what are physicians most afraid of? And I think that we don't think about quality or lack of quality because I think that's expected. We just have grown up taking the best care we can of patients. I think we think about our incomes. We think about our livelihoods. I mean, I think it's important. But I think there is one thing that matters more to physicians, and it's having patience. And so I'll give you an example. So I think most physicians would rather make less money per patient and have a full schedule than have 5 or 8 patients and make the same amount of money. I mean, we want to see patients. We want to take care of people, and I think that we, in some ways, fear not having access to seeing patients. And so, how can data promote adoption of a value-based care model? So how can you reduce total cost of care, promote a given pathway or protocol with physicians? You know, I think one way is you create narrow networks, right? So you begin to say, okay, folks, we're going to look at quality metrics, and you have those physicians and providers help develop the quality metrics that matter, that have an impact on patients. And then you develop pathways and protocols, and then you develop checkpoints, and that's where you're collecting data. And you're looking at adherence to those pathways and protocols. You're looking at outcomes, and you're looking at cost reductions. And then I think you're coming back to them and you're saying, okay, I'm in ear, nose, and throat doc. We need 6 ENTs in this clinically integrated network of 20 ENTs for a given payer product. Which 6 are you going to pick? Well, we're going to look at the data, and we're going to say which are providing the highest quality care at the lowest cost. Because this is a value-based care model, and those are the ones we're going to include. And so I think you begin to, in some ways, restrict access for some clinicians who aren't providing the highest quality care at the lowest cost. And I think that's going to change behavior. And so I think none of that really can be done without data that is trusted, that is real time, that is rich in the sense of having various inputs and real impacts on patients.
Okay.
Thanks for the question.
All right, the next question comes from Patricia, who says, please step back and define specifically what value-based care means to you and what standards/outcomes you believe measure this.
Well, I think it kind of depends on your population. And so, you know, traditionally value-based care is just the unit of quality per unit of cost, right? So that's the most traditional definition of value-based care. You know, I would argue that we can think of value-based care in terms of fee-for-service as well. It just kind of depends on where you are on that spectrum. And I don't think it's wrong to have a shifting definition of value-based care in a given market. Certainly where I'm from in North Carolina, the shift to value has been slower than in other parts of the country, like the Pacific Northwest. And so I think part of what what I try to do, we try to do when we engage folks is we try to understand where they are on that spectrum. And the point of the slide earlier was that there is no single, in my opinion, there is no single definition of value-based care. And we need to first understand how the market defines it in a given region, and then go from there and develop ways that you can succeed in that market to provide higher quality care. I think quality, quality metrics are universal, whether it's fee for service or some shared savings model. I just, they're almost a foregone conclusion, though, that we provide high quality care. And it's not always true, but I think the bigger focus often is on total cost of care. If I could I touch on one other quick thing?
Yeah.
Another question I get is around care coordination. And really what we're talking about is population health here. And how do we take care of populations of patients, however you define those populations, to improve outcomes sustainably? And again, sustainably meaning in a way that we can make money to support the program. And if you look at care coordination, it's also defined very differently depending on where you are, and therefore what drives value around care coordination. And some systems in some regions may look, or some products define care coordination around chronic care management, COPD, diabetes, heart failure. Certainly that's a component of it. Others may define care coordination more in terms of how do we handle referrals? How do we handle scheduling visits or consultations? How do we keep patients within the system, right? If we have a clinically integrated network and we've got all 28 medical specialties represented, and we're really proud of the quality we provide within that network, you want to keep those patients in your network. And so care coordination in that sense may be how do you coordinate the flow of patients through your system. And these are all defined differently by different customers with different needs and different markets.
Okay, we are at the top of the hour. Do you have a couple of minutes to stay on for a few more questions?
Yeah, absolutely.
All right, the next question comes from Wendelin, and this one's a longer one, so bear with me here. Thanks, Wendelin. She asks, in quality program reimbursement models, we currently have multiple quality programs that address the same problem, i.e. blood pressure. For example, MIPS, Mssp, ATENA, STARS can all address the same problem, all reference each other, but have some nuance or variance between them that make them different. Are you aware of organizations that are working to standardize value sets and data points across quality programs? And then she also added, such as the ONC or CMS.
Yeah, I mean, this is a big problem. I mean, and the classic example that I think that will resonate with all of us is around diabetes. And so we all agree that that the A1C measurement on an annual basis is important. Well, I shouldn't say that. Some don't. I mean, if you actually look at A1Cs, they don't necessarily correlate with long-term outcome. But nonetheless, it's a measure of can be a measure of compliance within a pathway or protocol that can impact ultimate outcomes for diabetics. So, there are different definitions of success, whether you're in a one-payer program or another. And so how do you manage all that? Well, I think it's really difficult. And I think there are two ways to think about that. One is you want to err on the side of being conservative. And so one of the things we did is we began to say, okay, what is the most aggressive number? So if it's 6.5, then make your dashboard, make your target 6.5. Make it the lower number for that A1C level. So in that way, you're standardizing what everyone's target is. And if you achieve 6.5, then you're going to, obviously you've achieved success in those programs that define it as 7 or 7.5 or 8 or whatnot. So I think that's the first thing. I think the second thing is to really take a look at what you're trying to do. And I think, if you're participating, if you're in a market that's got a lot of Medicare patients and you're trying to succeed in the Medicare Shared Savings Program, well, you're going to need to achieve certain metrics around that A1C and other metrics as defined by the program. There's not a single standard. You could certainly create one for your system. And what I would recommend you do is use those as defined by Medicare, because I think you're going to end up with kind of a Pareto approach. You're going to end up with the largest number or percentage of patients that are engaged in either Medicare, Medicaid, TRICARE, and some commercial payers that are going to adopt those metrics. And in many cases, those metrics are more aggressive than some of the commercial metrics. And so that's kind of, it's a great question. I think the last thing I would say is if you've got the right data analytics tool, I mean, you can certainly create dashboards specific to specific programs that have different measures of success within a given metric. Now, the question around data governance about, who do you show those to? Is it something that's managed at the administrative level of a CIN, or do you push that down to the physicians? Well, maybe you push it down to the physicians based on which payer products they're participating in. If you try to do this on your own or through an existing kind of dashboard within an EMR, it's a morass of confusion, and it's very difficult to do. And so I would encourage you, I guess the last comment, to find someone that can help parse that data, easily create modified dashboards, and then partner with that technology company to create a really well thought out data governance plan around how you're going to push that data down and to whom and who has control of it. So hope that answers the question.
She said makes sense. So
cool. I think that means I've heard enough.
We're going to jump down to this next question from Patricia, who asked, how is the Mssp cutting down on huge expenses to patients and taxpayers that still slant toward profits for the medical industrial complex and the quasi nonprofit mega health system providers that now extend their reach across the country?
So I think that there was a slide earlier. I mean, I think that we're seeing over $1 billion in savings in the Mssp program. And so I think they're doing it. And your question is how they're doing it. Well, I think they're aligning incentives. And I think they're forcing the alignment of incentives. And that means that they're paying for value and they're not paying for volume. And they're forcing systems and providers into downside risk earlier. I mean, if you look at, why are they doing that? Well, if you look at the low revenue ACOs over the past 2 years, and I won't call any out, but there's one in my region based in Virginia that's backed by a large investment bank. And, they've been incredibly successful in the Mssp. And it's because they don't own hospitals. They don't own bricks and mortar. They own physician networks. They manage and rally physicians around improving quality of care and reducing cost. And so, that's a scary thought for health systems that have a lot invested in hospitals. And I don't think hospitals are going to go away. I'm not suggesting that. We always need hospitals, nor do I think systems are going to go away. But I do think that systems are going to have to be smarter about how they use data. And I think that what's going to happen in the next 3 to 5 years are those systems that can effectively harness data, can have the courage to move smartly towards and embracing value-based care programs. I think those systems are going to survive and move on to kind of the next iteration of U.S. healthcare and survive this revolution. And those that don't are going to go away.
Okay. Well, it's 6 minutes past the hour. I think we'll just take one more question, if that's all right with you.
Great.
All right. So this question comes from David, who asks, given that social determinants of health are the #1 driver of outcomes, can you speak more about how addressing those social determinants fits into your vision of improving future outcomes?
So 2 thoughts. One is I'm a huge proponent of managing social determinants. I've spent a lot of my time in the developing world. I spent a lot of my time. We've just started a community health worker program in the state of North Carolina. We'll be starting that this year. So I completely agree that managing social determinants of health is critical to success going forward. I'm not sure it's the most important one. That's the one thing I would take exception with. I think it's important. I'm not sure it's the most important. Now, I think that if I back away from that statement, I think that in certain populations it's more important than in others. Obviously, social determinants are more impactful around patients that may not have good support structures. I mean, if you look at poor folks versus wealthy folks, I think it's very clear that that the social determinants are more of an issue. I mean, when I see patients in my office, right, we have a 15-minute policy, which I don't adhere to, but always. And if patients show up 15 minutes past their appointment, they're not seen. Well, I think that makes sense for a patient who has a car, who has the financial wherewithal to leave work, who has childcare at home, whatever. But I'm not sure that makes sense for a patient that comes in at 20 minutes after the visit because they missed their bus or their child's sick, or those are the social determinants. Social determinants are all about access, right? Access to care, access to transportation, access to good food, access to safe housing, access to pharmacy services, access to education, access to job training. So I think that if we want to begin to reduce that Gini coefficient, right, that we talked about earlier, I mean, you're much better off being a poor person in the United States than you are in most parts of the world. I mean, I think that's a fair statement. However, there is a disparity between the poorest in our communities and those that have money, and I think it's an imperative on us that we figure out how to use data to take better care of those folks. And I think those are the folks that are impacted by managing social determinants. The last thing I would say is, social determinants. There's no data architecture, right, that's been well defined here in the United States around social determinants. I think there was one that came out in the New England Journal several years ago. Certainly a lot of work around this. We are spending a lot of time here at Health Catalyst really understanding which social determinants we can first of all measure, right? Because many are financial and some are protected, and it's very difficult to get access to this data. But I think one of the things that I'm very optimistic about at Health Catalyst and probably some others, but Health Catalyst having an open platform, having the ability to ingest disparate sources of data from everywhere from the Census Bureau to the jails, to food programs, to community health centers, to HIEs, to be able to do this in a timely fashion. A lot of people can do this over time, but I think one of the advantages to the Catalyst platform is we can do this quickly. So the time to value is relatively short compared to many. And when you're faced with a problem or a Medicaid program, for instance, that's a capitated program, your ability to manage these social determinants, keep people out of the hospital, provide access to care at the appropriate level, I mean, those are really going to determine your success or failure in those capitated type programs. So once again, I think the financial pressures are going to push us more and more towards managing social determinants and creating programs like community health worker outreach programs all across the country. And in many places, they already have those that are very successful.
All right. That was great. Thank you, Dr. Caldwell, for staying on a little bit long there for that Q&A. We're going to go ahead and wrap things up. I want to thank everyone who's still on the line for joining us today and everyone who's already left us. They probably had to go at the top of the hour. Please do us a favor and complete the short survey as you exit the presentation. Your answers will help us to deliver more valuable content in the future. As a reminder, by midday tomorrow, you will receive an email with links to an on-demand recording, the presentation slides, and a transcription. We'd also like to invite you to join us for our next webinar, State of the Union, on Wednesday, May 15th. The presentation will feature Aaron Mock, Senior Director and National Spokesperson at the Advisory Board, as he provides an objective analysis of the biggest trends and market forces impacting hospital and health system strategy in 2019. On behalf of Dr. Caldwell and all of us here at Health Catalyst, thank you for joining us today. This webinar is now concluded.
Thanks so much for joining. And please go out, be a burning bush for healthcare, make a difference. You've got an opportunity, you got a responsibility. Thank you all. I hope to meet you in person.
Love it.